طب عايز تحط Hello Professor Bhutani.
Good morning, everybody. Or good evening
الصوت
to
مش
you.
مسموع يا جماعة. Unmute. Can you hear me?
Yes, I can. Good morning or good evening, everybody. Greetings from Stanford campus to all of you attending the meeting.
Okay, we're starting the lecture right now. ابتدي من فضلك.
Good afternoon, my dear colleagues in Cairo, those who are attending this meeting. I'd like to thank the organizers, the chairpersons of the meeting, and the chairpersons of this session for their kind invitation and allowing me to participate at this meeting and conversation. I have chosen a topic on looking at the best practices of benign outcomes for neonatal hyperbilirubinemia in the Arab Republic of Egypt. I'd like to speak about this topic from two perspectives. Number one, of my personal interest in the care of babies with newborn jaundice, but also in the global prevention of connectris. This is an area that the faculty in Cairo and in Egypt have led us to a better understanding. I have no conflicts to disclose, and I will commence with the fact that we now have the capacity to have a review of new evidence that has emerged in the care of newborn babies. Firstly, newborn jaundice should be benign. Mortality in a mature healthcare setting, such as Europe, US, and in certain urban cities of the world, the death rate from connectris is almost less than 3 per million live births. Preventive and crash course approaches have been implemented to prevent morbidities. Point-of-care bilirubin testings are now affordable and available worldwide. More importantly, point-of-care intervention is available in most nations. The use of photons judiciously used by you, preferably at 478 nanometers wavelength, using LED lights are becoming a standard of care, such that exchange transfusions are now rare and may even be eliminated with your help. Yet globally, there is a profound disparity of outcomes. Our colleagues in sub-Saharan Africa and South Asia unfortunately see an unduly high burden. Most of these changes have occurred by recent research and the incorporation of this research into the guidelines from organizations such as the American Academy of Pediatrics and the National Institute of Clinical Excellence in the UK over the past 20-odd years. They have provided specific directions that have helped unify our approach. I would like to see how Egypt has fared, and this was brought to my attention just a few months ago. The contributions to the better management of newborn jaundice from Egyptian researchers has been remarkable. Over the last 2 decades, we have seen a burgeoning amount of reports in major journals that have helped inform the American Academy of Pediatrics and its evidence reviewers on how to use this evidence and incorporate it into practice. Such that if we compare the data from 1990, when I earlier visited Cairo, to that of now, the neonatal mortality in all three phases, that is early, late, and post-neonatal, has declined every year by a remarkably sound percentage. More importantly, mortality from connectress, especially acute connectress, has gone down from what was then about 340 per million live births to 30 million live births. That is a remarkable and a dramatic achievement. Yet, as you can see, compared to the more mature healthcare settings of the world, this is about 10-fold higher. This dramatic decrease is not just an isolated event, but as you see that it has been occurring every year as of 1990 with dramatic changes in the last decade. And so it has taken this long for the changes that were initiated at the urban teaching hospitals that penetrated through the country and are moving down the last mile of the public health spectrum. It is this journey to the last mile that is often the most challenging. We know and we hope that at every birthing facility, that if a baby is born, all babies will become hyperbilirubinemic with a bilirubin value of more than 2 milligrams per deciliter. 80% of them will develop connectress, which is just a clinical sign, not necessarily a medical disease. 6 to 8% of those babies will have bilirubin values above the 95th percentile that puts them at a high risk for developing severe adverse effects. Most will have a predictable benign outcome, and most good outcomes are due to optimal nutrition and gut maturity. Only about 6 to 8% of those babies will need treatment with phototherapy. As I indicated, a few will need an escalated or urgent phototherapy, and a rare number will need an exchange transfusion. Almost none will die from connectress, and none should get or die from connectress. These are now well-established pieces of knowledge that have been well incorporated and should be incorporated even at primary healthcare settings. The new AAP guidelines has provided a framework which we can adapt to any nation. First, every baby needs to be tested for bilirubin soon after the baby is born, preferably between 24 to 48 hours of age. These guidelines were just published a few months ago and are gradually being incorporated in our practices. These guidelines stem from about 5 to 8 years of discussion and review of evidence and writing and rewriting the guidelines so that every aspect of the pediatric care was addressed. The major change in this guideline is that when a bilirubin measure is made, that value is no longer just for screening, but to decide at which level the baby should be treated with phototherapy, so that within a day of birth, one can decide if that baby is likely to need treatment with phototherapy and thus should be followed accordingly. That's a major change in our planning and our approach, because we want to get to the babies who need phototherapy. A systems approach is thus needed and has been advocated as of 2004 and reiterated in these guidelines. First, know the bilirubin level at which the baby is most likely to be treated. Know which baby is at risk so that you can scrutinize that baby. Know which baby is at most risk so that you can closely follow that baby. And then know while you're following the baby, if the baby is getting optimal oral nutritional intake by assessing the gut maturity pattern. Now, the precise bilirubin at which you will use a light therapy, so that is well known to everybody who's going to take care of the baby, know the best light you want to use to convert the toxic bilirubin, and know how much of light you need to use so that you may escalate the care as you reach dangerously high levels. And then, if you reach that point, invite an expert to conduct an exchange transfusion. It just cannot be done remotely. Know that your approach, after doing all of that and protecting the baby, that you've had a benign outcome. So to do this, let's find out who is at risk. We now need to interpret the bilirubin test according to the baby's race and ethnicity, gestational age in completed weeks, the baby's age in hours, assess if the bilirubin is rising fast, looking at the rate of rise, look for clinical risk factors, and then identify the key neurotoxic risk factors. This will help you determine the specific bilirubin threshold at which to start treatment. You can use a non-invasive bilirubin testing, especially as you get to remote areas where blood testing is sometimes a challenge. According to a recent Cochrane review that is in press at the moment, we looked at about 27 studies involving about 5,800 babies worldwide. And we found, not unexpectedly, that the transcutaneous devices are pretty sensitive, between 74 to 100%, but the specificity is rather poor, going to as 18% or at that low number. The variability, especially in the specificity, is due to the quality of the devices, but also to the gestational age of the baby, the age in days, the postnatal age, the ethnicity, race, and skin pigmentation. So it is for this reason we often have posed, and is worthy of a comparison, is that you can just assess the color of the baby with a ruler. This work was done in Bangladesh by Dr. Annie Lee, one of the persons that I had mentored, who developed this technique to compare colors of the skin of the baby in different skin pigmentation. And that bilirular device is probably a very cheap device that can be used to start screening as a first level screener to decide in whom you need to get a bilirubin done. But once you try to use any devices other than the serum bilirubin, remember it needs to be referenced to a very standardized assessment, because bilirubin measurement is rather complex, especially if you want to do it accurately. Now, to know which baby is safe, we have two possible strategies, one that I propose and the second proposed by the AAP. For the last 20, 30 years, we looked at the nomogram offered by us, which indicated that if a bilirubin value for a baby was below the 40th percentile, then that baby would have a benign outcome and would not likely to reach an adverse outcome. That guardrail has persisted and maintained and has been proven by many other studies that have been done worldwide. So that is one approach, that you can plot the bilirubin on the nomogram. If it's below the 40th percentile, you don't have to worry about that baby as much as all the other babies. The second, proposed by the new guidelines, since we're looking at the threshold for phototherapy that we want to determine, that if the bilirubin value that you have obtained is more than 7 milligrams below the threshold value determined for the baby at age 24 to 48 hours, then that baby needs a routine follow-up after 48 hours of age, with still within the first 5 days after birth. So there are two possible strategies that can be used. And obviously, if you're going to compare them, then you need to study them. Looking at gestational age to guide your bilirubin value interpretation, you must know the gestational age fairly precisely. You can't do it by examination alone, because that normally has a variation of plus or minus 2 weeks. But using the last menstrual period from the maternal history or from the fetal ultrasound, if it was done in the first trimester, common in the US, but I'm not sure it's very common in Egypt, that will help you categorize the babies per week. Because of the variabilities in the measurement of the gestational age, we're looking at completed weeks of gestation. So if the baby is 35 and 6 weeks of gestation, that baby is at 35 weeks. And if the baby is 37 and 4/7 weeks of gestation, that is baby at 37 weeks. So knowing the gestational age is crucial to help you determine at what threshold a phototherapy treatment is essential. The other risk factors that are in place are also well known to you and have not changed since the previous guidelines. These include prematurity, early onset of jaundice, a rate of rise of bilirubin more than 0.2 milligrams per deciliter per hour, use of phototherapy in the baby or in the family of the baby, and isoimmune hemolysis. And there's a lot of emphasis in these guidelines on G6PD deficiency, given our mixture of patient population and our demographics. Hematoma, suboptimal feeding are still there as major risk factors, along with Down syndrome and macrosomia, or being large for gestational age. So nothing new to add here. Tracking the gut maturity and oral intake is also an important part of our new guidelines, which focuses extensively on breastfeeding and assessing its adequacy, but also looking at a way to look at stool color changes over the first 7 days after birth as milk volume increases. This is a useful guide that tells you that the high-producing bilirubin baby in the first few days of life can be balanced very nicely if the gut matures. So that coordination is something that you can engineer. The focus is on identifying those at most risk for connectors. And those are factors that have been associated with neurotoxicity. First and foremost, we have shown in our previous reports that both high bilirubin values and connectors are more likely to occur in babies less than 38 weeks of gestation. And that is why the timing of elective cesarean section has been altered in the US. Secondly, the recognition of hemolysis, keeping in mind that we're worried about G6PD and eliciting a family history that is suggestive of inherited red blood cell disorders. So all this needs to be a part of a history taking. The sepsis, suspected or otherwise, and then hemodynamic instability, especially in the preceding 24 hours, and low albumin values, which are often associated with prematurity or illness. So these 5 factors have always to be considered as you're trying to determine this number of phototherapy. So here are the curves that have been developed on the basis of consensus and a lot of thought and debate. The challenge in defining this curve has been to define curves for each week of the gestation, because your threshold lowers with each week of immaturity. There were 2 factors that we had to keep in mind. Number one, that if the baby was of term 40 weeks gestation and had no risk factors whatsoever, then in that baby, we could enlarge the area under which the baby could be treated so that the phototherapy guidelines were at their maximum. But if the baby was premature, then they needed to be lowered. If there was one or more neurotoxic risk factor, that too would change the thresholds for phototherapy. Now, all of these make logical sense, and there's evidence to prove it. But the question is, how do we show it to you and how we put it into practice? And this requires the ingenuity of a software program. So the AAP, as well as UpToDate and other organizations, have come up with software that are freely available in the public domain or can be made by you. The importance of these graphs is that you may not remember them, but you need to have some sense as to where are the numbers and what kind of numbers are we dealing with. So what I've highlighted in the next slide is looking at the bilirubin value at about when it plateaus in the threshold. It rises for the first 72 hours to 80 hours of age quite precipitously, and then starts to plateau. So if you look at the numbers at 96 hours of age, when you know that your maximum numbers and you don't want to exceed them at all, then look at this table, where we've highlighted for each week of gestation the thresholds for phototherapy and for exchange transfusion. I draw your attention to the spectrum of these values. The highest spectrum at which we would start phototherapy in the most healthiest of babies without risk factors is now about 21.6. But if the baby is at 35 weeks of gestation and has one neurotoxic risk factor, that value comes down dramatically to 16.1. And so you can see the spectrum changing from 16.1 to 21.6. So as you see such numbers, you really need to go in and assess the precise gestational age and look specifically for those 5 neurotoxic risk factors. For an exchange transfusion, the spectrum ranges from 21.5 to 21.1 to 27. All right. We'll come to how these numbers are further altered by the bilirubin albumin ratio. So you may not remember these numbers, but I think using a software calculator can help you. And then also, alternatively, if you do not know the gestational age, what I propose is that we can just divide these babies into term and late preterm, and there you can see the thresholds at which you have a certain range. So that if a baby is late preterm, you need to be considering a phototherapy between 18.6 and 20, and being closer to 18.6 if you're unsure. All right. So that gives you a range. Similarly, for an exchange transfusion, and you may note down these numbers, and I'll have them be available for you in the subsequent literature. It is now well established that after 60 years of prescribing phototherapy, that this is a safe and effective standard of care. There's been a lot of discussion as to the side effects of phototherapy, and actually those are minimal. There's been a concern about mutagenesis of cells in the skin epithelial, high risks of cancer, and diabetes and epilepsy, and so on. And all of them need to be worried about. They're under investigation, but thus far, after 60 years, we have not seen any evidence. If there was an iota of concern that the American Academy of Pediatrics had for the use of phototherapy, then they would have used an informed consent to prescribe phototherapy. and none has been considered. However, that does not mean that we do not like the abuse of phototherapy. There's no reason to leave a baby on the phototherapy unnecessarily. And that is why the physics of phototherapy needs to be well understood. Any indigenous device that is used must be tested to make sure that it has eliminated ultraviolet lights. It is a contamination of these lights with ultraviolet light that may be a risk factor for the occurrences of skin malignancies. Using LED lights allows us to use a precise wavelength and allows to use as a light that is not hot. So new facts have emerged about phototherapy. Number one, light, we understand, is not a continuous beam, but a series of photons that are emitted from a light source. And those photons carry energy. The energy of the photons has been well described and measured by the Einstein equation, which I do not understand, or at least I do not remember. So I have to look at this Planck constant and wonder what it is. Regardless to say, as I calculated in this energy calculator, that for every 1 millimeter of wavelength, you can look at that energy of photons in that wavelength and convert it into joules, into energy. So just think that the baby's skin is being bombarded with energy. That energy is bound to have some effect. And it is this energy that one has considered as a possible oxidant stress, or is one that is considered as a reason for a high rate of mortality or a higher rate of mortality in the extremely low birth weight babies, less than 600 grams. So we don't want to abuse the source of light, but we want to use it judiciously. So looking at these pixels of light, which if when filtered through the prism give us a blue-green light, we see the range and the spectrums of the blue-green light as to how they penetrate the skin depth. The green light penetrates just the right amount of depth so it can reach the subcutaneous tissue and the vasculature. And it is in the zone of 460 to 490 nanometers that we have found phototherapy to be most effective. As soon as this light is irradiated on the skin, the conversion of the photoisomers begins to take place. And the one that we are interested in is in number 4, 4Z15E bilirubin. It starts to appear within seconds of administration of light and peaks, as you can see, almost in about 8 to 9 minutes after exposure to radiation. The effect of the light is thus almost immediate as soon as you turn it on, and that it continues to increase over the first 2 hours, and that is the key critical period of using phototherapy. Remember, when you're using such light that has been filtered, you're harnessing a part of the sunlight's rainbow to give the precise prescription at which the bilirubin chemistry molecule can be altered to a non-toxic formulation. The novel knowledge has been generated over the past few years. It started with Dr. Evison thinking that one spectrum 490 nanometers was more effective than 450 nanometers. And he started looking at what was then called the turquoise light. This action spectrum was actually calculated by Dr. Lamola and ourselves back in 2014 as being at 476 nanometers. In subsequent randomized studies that Dr. Ebison conducted, he looked at 459 versus 478. 459 was the classic blue light, and 478 was the blue-green light, or the turquoise light. And he looked at the comparison, and what he saw was an effective high rate of reduction of bilirubin. If you look at his data, his calculation of the action spectrum is shown in the right panel of the slide, and the effect of bilirubin reduction being higher with the blue-green light is shown in the left panel of the slide. It is for this reason that we have asked and requested various engineering firms to start considering providing devices that are focused at 478 nanometers. It should have the shortest tail, so it should not spread into a wide wavelength, but the narrowest wavelength. To do so, you need to use LED light sources that helps to engineer the wavelength to the precision that we would like to use. It is in this approach that we think that the LED lights will become the standard of care worldwide, and this is the time we need to reinventorize our supplies to take away the fluorescent lamps and the other lamps and using LED light sources only. So the key characteristics of the phototherapy listed in the technical report, both the earlier one as well as the updated one, is to provide an ideal light source, starting with a dosage of about 30. One can range it from 25 to 35 for prematurity, but not exceeding 35 because we do not have any data on the toxic effects of a higher dosage and the more energy bombardment that the skin is likely to receive. Providing light to both surface area is ideal, but if you want to do it at one surface at a time, remember you're about halving the dose with that therapy. Timeliness, well, always when you need to use it, especially now with these very wider margins of phototherapy thresholds, it needs to be urgent. You can't wait for hours. This baby needs to be rushed to the hospital where the light is available. So these are the babies that we really think need to be transported in an ambulance rather than in a casual drive to the hospital. Continuity of care, that after the 2 hours of phototherapy, it's okay to interrupt the phototherapy for bonding, feeding. In fact, we plan to do so with cycle phototherapy that is being evaluated for extremely low birth weight babies. The efficacy of the lights is measured by the rate of decline. The average duration in the absence of active hemolysis is about 24 to 48 hours. If the baby has RH disease or severe avian compatibility, then a longer duration may be necessary. When do you escalate phototherapy? Well, if you're 2 milligrams below the exchange threshold. If you start vigorously, you have 2 hours to almost prevent the need for an exchange transfusion. This work has actually been reported so well and eloquently by the work done in Cairo. So the ability to develop a crash cart approach and this value has been proven. It is with this data, we think that IVIG is an optional therapy. There's been a lot of debate about it. I think because of the cost, we think phototherapy is cheaper. But if you have failed to use phototherapy earlier, then because of that failure, you may want to consider IVIG. And then in these guidelines, we are promoting the use of bilirubin albumin ratio. Again, this work has emanated from Cairo reports and talks about the use of the bilirubin albumin ratio, that while you're considering an exchange transfusion and you have that 2 hours to obtain the albumin value so that you can decide at what threshold to use the exchange. The exchange transfusion is to save life because as acute bilirubin encephalopathy progresses, it is the respiratory failure that determines the baby's fatality. An exchange for a rising bilirubin or any signs of acute bilirubin encephalopathy will not prevent bilirubin neurotoxicity. All right. That is not the goal. You hope it is the goal, but there's no guarantee. And so the idea is prevention, and the idea is to get to the baby before an exchange transfusion is needed. And all of that requires anticipation of the public health system. Exchange transfusion represents to me a failure of our public health system. Here are the bilirubin albumin ratios that are well known to you. I'm bringing coals to Newcastle, and so you know you use it way more than I would in my nursery. The question then is, when you have managed such a baby and you have prevented escalation and you have prevented a benign you have prevented the need for an exchange transfusion, is the outcome benign? Now, there were several myths that we had, and I think the Egyptians have helped dispel some of these myths. A simple normal examination at discharge does not mean the baby is going to have a benign outcome. An automated ABR at discharge is also not going to guarantee a normal outcome. A normal auditory brainstem evoked response at the age 3 months is valid if it has been verified by an audiologist. If that is normal, then that baby is saved. A normal neurological examination at 12 to 8 months also does not guarantee normality, especially if the baby is going to manifest subtle signs as he or she gets older. So normal neurologic examination at age 5 years is helpful, but that baby needs to be evaluated for subtle signs of coordination, awkwardness, and muscle tone. These harbingers of bilirubin-induced neurological dysfunction syndrome, all right? This is a dysfunction. This is not a damage at this point. And so it is at school-going age, at the ages of 6 to 7, when hearing, reading, speech, and language development can be assessed. And if those are normal, then what you had managed 5 years, 6 years earlier help you reassure the family that your management was appropriate, sound, and safe. And that is why this practice is difficult and complex for a pediatrician. The thing now is, what can we do at primary healthcare centers? Because we don't want subtle damage occurring at our primary health center levels. So the recent remote health supervision that has evolved because of the COVID experience and the use of telehealth has given us some umbrage to move forward in this area. We can now look at affordable bilirubin or color estimations with the help of a remote camera at a home setting or at a primary healthcare facility that is not well served. A remote daily health checkup for the first 5 days after birth is also now feasible with the help of phones as well as camera hookups. It is the unfettered access to medical phototherapy that has become a dominant search. The use of LED lights makes it affordable, and these have been tested in rural areas, in primary health facilities, both in South Asia and in sub-Saharan Africa. We are considering and actually testing home phototherapy in a rural Bangladesh village and have enrolled several patients in that very safely and hope to be able to write about it in a couple of years. But that has one consideration to keep in mind, since we have affordable phototherapy units that can be provided to the family. The work done by Tina Slusher, our dear colleague in Nigeria, on filtered sunlight also has a possible role, and you have already investigated this in your settings. The key element here is that from the home or the primary healthcare center, the baby can be moved rapidly in case the baby is at most risk or at risk of requiring an exchange transfusion. So that needs to be kept in mind. And as I already said earlier, that it is time for us to consider that a baby who's being rushed for an exchange transfusion reach the hospital with an ambulance, preferably with a phototherapy device on board. So in a primary healthcare setting, knowing which babies are safe is key. And if you look at the 40th percentile, I'll draw your attention to bilirubin value of 10, which is easily and accurately determined by most non-invasive testing, including color estimation. Non-invasive devices become more difficult to use for accuracy when the bilirubin value is 12, 13, or 14, and their variability increases. So if we can accurately say that the baby's bilirubin value is less than 10, then we don't have to worry about that baby. And about 60% of the population resides in those below the 40th percentile. So our mission, if I may say so, in places like Egypt and other parts of the world, which are emerging high-income countries of the world, that we have to reach that last mile of primary healthcare to provide equitable healthcare. We can do it with simple 7 steps. Know which baby is safe, whose bilirubin is less than 10 for 48 hours of age. Provide these babies remote follow-up, okay? And those who are at risk, follow them more closely. And those who are at most risk are about 40% of the population. Know which babies are at most risk. Those are the neurotoxic risk factors, maybe about 6 to 8% of the babies. Double check their gut maturity with serial remote follow-up, and then know and determine and broadcast the precise bilirubin value at which that light must be needed for that bilirubin. If the family knows that the phototherapy is going to be needed at a bilirubin of 15 or 16, then they will get to the light source or be brought to the light source. Know how to access the best light source. And that's for about 10% of the population. So it can be centralized, or in some areas can be de-regionalized to home care. And now we know which babies must escalate care, and those babies, often less than 2%, can be transferred. We need to align individual facility and community capacity to make this happen, and that is a task at hand. So in summary, evidence exists to implement best practice. We know which baby is most likely to be safe. We now know which baby is most likely to be at risk so that we can follow this baby under supervision remotely. We know which babies are at most risk. It's easy for us to assess gut maturity. We have to share and broadcast the bilirubin at which that baby must be treated with phototherapy lights well in advance of that need for that light. And we know how to access the best light source in the market. And we can easily transfer the babies, as we have learned from the COVID experience. So with these 7 steps, please help us eliminate exchange transfusion, because it needs to be retired. Thank you so very much. Appreciate this opportunity, and I will be now available for questions and answers.
Thank you, dear Professor, for this very important lecture, and thank you for all the effort sharing us the information and the statistical data from Egypt, especially knowing the reduction of the risk of mortality and morbidity from 360 up to 30 children per million, which need to be less and less by time, especially after attending this lecture that will lighten the way for all the pediatrician later on in my country. Thank you, sir. I think we can open the floor for 2 or 3 questions.
We have Professor Nahid Fahmy and Professor Iman Saoud and Rash. We have passed the protocol.
Professor Bhutani, we are really honored to have you in our conference, and we miss you very much in Egypt. We hope to see you this time, but next time, inshallah, you will be with us. So I think you know me, I'm Nahid Fahmy. I have a question that we frequently encounter in our practice is the cases of almost full-term or late preterm babies who have non-hemolytic, unconjugated, unspecified hyperbilirubinemia for a long duration that may sometime or almost exceeding 14 days up to 1 or 2 months. What can we do with them as a management? First investigation and management.
Good afternoon, Madam. It's a pleasure to see you again. And thank you for all the work that you have done at the primary care settings in Egypt. Thank you for that. I think the issue that you bring forward is a prolonged unconjugated hyperbilirubinemia. And there's actually a slide that I can share subsequently with you that attests to that and is in the guidelines. Other than the usual causes that are considered, such as urinary tract infection and hypothyroidism, as well as inborn errors of metabolism that may prolong jaundice, such as galactosemia, and all need to be excluded. If the jaundice persists after the age of 7 days, there's one question of treatment, but the other question is finding the cause. And a lot of the work done in San Diego by our colleagues on the UGT enzyme maturation has shed some light on this. And it is this association of an immature UGT system, often called Gilbert syndrome, that often exists in about 6 to 8% of the population. Surprisingly, this defect or this genetic mutation coexists with G6PD deficiency. So G6PD deficiency is quite unique in Egypt. And I wonder whether what you're seeing is an effect of this UGT mutation in the Egyptian population. And that would be something of an interest. So the management of such a baby is that it is a part of maturity, and it is not really a big deal. It allows an individual to have a higher bilirubin value, which has a good function, which is the antioxidant function. If that level prolongs as is higher than 13, 14, and like 17, that needs to be treated. And that can either be treated with certain amino acids found in casein hydrolysates that can be supplemented with breast milk or with the use of phototherapy. And the guidelines has offered these phototherapy levels going up to 2 weeks of age. Before it used to be for the first 7 days, now we go up to 14 days. So I think it is a genetic condition that we are most likely seeing, that it is masked and it has been mislabeled in many conditions as breast milk jaundice. It is not the breast milk jaundice that is causing the problem. I hope that answers your question, Madam.
Yes, of course. Thank you very much. Actually, we had done a research 4 or 5 years ago for the gene mutation in these cases. And we found some cases, but it was a small-scale study that needs to be expanded to see if we have a certain affordable or technique to minimize the cost of the testing so that we can make it as routine for these tests. Thank you very much.
Thank you, Madam.
Thank you very much for having you with us. I'm Iman Saoud, if you still remember me. You
yes, very much.
Well, it was a very good idea to have you with us and attend with us this conference. Actually, I have nothing to ask about. I just wanted to thank you very much. And we're really, really happy to see you. Thank you.
I would like to thank you on behalf of all of us in the US for the work that you helped initiate and in helping mentoring Dr. Iman Sikandar, who has been a valuable ambassador of Egypt for us at the American Academy of Pediatrics. Thank you, Madam, for all your efforts.
I just have one question, sir, about the impact of the hematocrit of the blood that is used in the exchange transfusion with the effectiveness of the exchange transfusion. Because now we're not using whole blood, we are mixing the plasma and the packed RBCs. We are always worried that we will give anemic blood, but I think there is some recent evidence that maybe being not over enthusiastic about a lot of RBCs might benefit the bilirubin removal more. So if you can elaborate on that for a minute.
So you do far more exchange transfusions than we do. When we do exchange transfusions, and we too combine the red blood cells and dilute it, and our choice of hematocrit is generally at about 40%. We never want to exceed higher than 45, not only for the clotting effect and the catheter blockage, but we don't want to create any hyperviscosity. Now, having blood that is more anemic, like 35 to 40%, is open to discussion. The value of a slightly lower hematocrit is to allow more phototherapy lights to go through the blood so that bilirubin can be reduced more effectively. Remember, hyperviscosity creates a barrier for the light to enter the blood so that the bilirubin can be converted. But going very anemic is also a concern, and whether that can be corrected later on if there's continued hemolysis with a booster transfusion is always a possibility. So I am very reluctant to use a high hematocrit level. I prefer to remain at 40, but I can see a case being made for lower than that at 35 to 40 range.
Thank you very much, sir. One last question, and then we will shift.
Dr. Bhutani, hi, I'm Rasha. I hope you still remember me.
Yes, very much. Rasha, Gamal.
Yeah. So Dr. Nahed is having another question, please.
If you allow me, sir, I have a second question about
Sure.
the IVIG. Sometimes we cases which have very high level of bilirubin. In some of our researches, it may reach up to 70 milligram per deciliter, and we are obliged to do exchange transfusion. But if it is a case of hemolytic unconjugated hyperbilirubinemia due to RH incompatibility, we think of giving, we have to respect the time we have until we have the blood for exchange transfusion. Sometimes it is more than 6 hours until we get the blood. Do we give IVIG at the time? And the exchange transfusion, if it is done within 6 hours, it will remove all the IVIG, so it is useless, or we still have some benefit from it?
Yes. So I agree with you that in a condition with an RH disease, IVIG is most helpful. It has been proven to be helpful for RH disease. And while you're waiting for an exchange transfusion, it has an immediate effect. And it's that immediate effect and kind of halting hemolysis and adding that bilirubin load from going up in those hours or minutes that you're waiting, it is well worth its dosage because you're protecting the brain. Whether the IVIG is removed completely after an exchange transfusion is not known or has not been well documented. And the only reason to repeat it if there is a continued hemolysis after the exchange transfusion, so that you see a further higher rebound of bilirubin, and therefore a second dose may be needed. I don't think it's essential, but there's so many variabilities of RH incompatibility. And as you know, RH incompatibility process continues for about 6 weeks or so. So to halt hemolysis, the IVIG is helpful. Thank you. Thank you for your experience.
Thank you, sir.
Thank you very much. Muhammad Fadl.
Good evening, Mr. Bhutani.
Ali Su.
Good morning, Mr. Bhutani, Dr. Bhutani. I have just two small questions. You mentioned that the gut maturity is crucial in decreasing the bilirubin level, and we have to have a look at the stools of the baby. Is there a chance here that we can use prebiotics or probiotics or supplementary to the milk in this field in few days of life to enhance reduction of the bilirubin? This is my first question. And the second question is about the remote checking of the bilirubin. How did you do it during COVID disaster? Thank you.
So I think the idea and the concept of probiotics is gaining a lot of attention. And we as a medical community are looking more kindly at probiotics. How does that change the stooling pattern and bilirubin elimination has not been well studied. And I think it is an area of an interest as well as of inquiry. So I hope that you may help us lead in that area. For babies in a remote setting who are under phototherapy, that's the question? The second question, sir?
Yes. How did you make a connection with them, or you said the camera?
Yes. So I think just a simple phone, a smartphone is all that is needed with COVID. I mean, we have now really worked on good telehealth systems so that it's, I mean, they're good quality cameras and that are easy, and most families have access to them, or a healthcare worker can have access to them. So you can look at the baby, but and you can look at the stools. If you're using an icterometer or a transcutaneous device, then you can also verify how that is being done. So a remote 5-minute visit is all that is needed at home, and a healthcare worker who's visiting the home can be a liaison, or if the parent is capable, then just a direct conversation with the parent between the nurse and the parent is often more than enough.
I mean, there's no way to check the bilirubin level through the cameras?
There have been some efforts, but there have been great difficulties with that. Our friends in China had come up with a device, but it was so variable that it was like a toss of a coin. And so you need a probe to put on the baby's skin. You have to blanch the skin so that you can get to the skin without the blood flow in it. With a camera, the baby is circulating blood in the skin, so you don't have that digital pressure effect. So that is still a challenge.
So I think we have to come to the end of this session. We would like to ask 100 more questions, but we're already very late with the program. We want to thank you so much. We are truly honored that you gave us your time and that you committed to be with us. And we hope you will be with us in further conferences.
It is my pleasure, and thank you so much. Thank you so much.
Thank you so much. دكتورة ولاء حضرتك تقدمي second speaker.
بسم الله الرحمن الرحيم. الأول حابة أشكر الأستاذة الدكتورة إيمان عيادة والأستاذة الدكتورة رشا جمال أساتذتي وعز الناس على قلبي على اليوم. أنا مش عايزة أقول المؤتمر، عايزة أقول المهرجان العلمي اللي إحنا فيه، ويا رب إن شاء الله تبقى بداية ورجوع موفق، وإن شاء الله تتكرر كل سنة. حابة أشكر أستاذتي الدكتورة إيمان اسكندر والدكتورة معتزة على اليوم الجميل ده. ودلوقتي أقدم صاحبتي وحبيبتي الدكتورة سلمى الفوشي لتوبيك تايتل On Mother's Milk protect against neck and poor outcome.
هو مش هو ده مش هي دي. At first, I would like to thank